So I would like to present based on these 6 slides, where I'll be talking about the recent advances and what is the need for advanced metallurgy in spine oncology. Why should we challenge the conventional treatment option based on the titanium implants? The role of en bloc and the separation surgery, and how does the metallurgy helps in the treatment aspect. Following this, I will talk about the radiosurgery and the dosimetry calculations which are required. And then we'll just dwell upon the evidences based on to this, and we'll have a sneak peek to the future of spine oncology. So what is the need for this advanced metallurgy? That is because of the recent advances we have now. And it is because of the 3 myths which has been busted in spine oncology. The myth 1. So the myth 1 that has been drilled into our minds is radiosensitivity and the radio-resistant tumors. Tumors like small cell lung carcinoma, marrow-infiltrating lesions, myelomas, they are highly sensitive. Whereas sarcomas, RCCs, melanomas, they are highly resistant. So this has been a myth which has been drilled into us. But now all tumors, irrespective of their histology, are radiosensitive because of the advances in radiation oncology, and that is called as the SBRT, that is the stereotactic radiation. So it is because of these advances in radiation oncology that we have to get upbeat as a surgeon to have advanced metallurgy. Coming to the second notion which has been given to us. So this is a case of renal cell carcinoma with an L1 lesion. And based on the Tomita classification, the Japanese famous classification, the answer to this question is an L1 corpectomy. So if you use the present system of classification, that is the Mark Bilski's norms classification, the treatment aspect for this case is just a separation surgery. That is, you create a safe corridor by giving a 360-degree decompression of the spinal cord, and then the radiation is being sent to the anterior part of the tumor. You create a safe corridor, and that's all is required. So if you go with the legendary classification, that is now called as the Tomita classification, the answer is L1 corpectomy, and the blood loss is 2 liters. But if you go with the newer classification, that is the norms, you just do a 360-degree separation surgery, and the blood loss is 700 ml, and the result is almost the same. The second thing is, when you do a L1 corpectomy, you have to give an anterior support. And following that, when the patient is being subjected for RT, when the radiation goes in, it gets deflected because of the metal. Whereas in a separation surgery, it goes directly into the radiation, directly goes into tumor mass, and after 2 months, it gets calcified. So you need not get an anterior support also in these cases. So this is the second myth which has been busted because of the norms classification. Myth number 3. So this is about the titanium implants, the gold standard in present generation of spine surgery, the titanium implants. So because of this titanium implants, what you see is when you put radiation across, all the radiation gets scattered because of the metal. And the backscattering of the radiation limits the delivery of the radiation to the tumor tissue. So there is unequal distribution of radiation. So this is on the first image. Now kindly concentrate over the second image. So now to make sure that the tumor reaches the opposite end of the implant, the radiation dose has to be increased. And that is where the issues happen, that is organ at risk. If you see this chart, it shows all the organs and the dose. And of all the organs, it is the spinal cord which is most sensitive to the radiation. So if you increase the dose of the radiation to reach opposite of the implants, there is always a tendency of myelitis. And that is why you see, in case of metastatic spinal cord compression, post-RT also, some patients don't recover. It is because of patients getting myelitis. So this is a case of separation surgery which I did for a renal cell carcinoma D10. So what we do is we do a 360-degree decompression. We pass on the vessel loop, and this vessel loop is of 5 mm. This makes sure that the anterior the cord has a space of 5 mm, and I do an intra-op ultrasound to make sure the anterior part of the spinal cord is also decompressed, and there is a channel for the radiation to go inside the tumor tissue. So these are the reasons why we need a better implants for patients in spinal metastasis as well as primary spine tumor. So the answer to these questions is the present generation is trying to find for the future. And the answer is the carbon implants. So this is the future. And here is the introduction to the peak carbon radiolucent implants. So radiolucent implants, they are biocompatible polymer. And based on the finite element analysis, the tensile strength is as similar to as the titanium implants. Secondly, PEAK allows a clear visualization of the bone. This is crucial for the post-op monitoring in case we have to find for a local recurrence and for assessing the fusion. Second, post-surgery, if the radiation people, they have to plan for the dosimetry, it gives them the entire vertebra to assess the tumor volume. And the third, the PEAK implants, they got a better biomechanical pull strength, very similar to a titanium implants. And the carbon fibers can be augmented with tricalcium silicate so that there can be better calcium scaffolds. So these are the advantages of the carbon implants, and they are biomechanically similar as well as biocompatible in the human body. So, taking a sneak peek into the evidence-based literature, so these are the 4 centers in the entire planet which are working on to exclusive spine oncology. These are the MD Anderson Center, MSKC, the Rizzoli, and the NCC in Japan. So we'll just touch upon the evidences which have come from these 4 centers. So this was published in JNS, and this was published by a multicentric trial from Japan and the US. So what they found was, out of the 28 spinal tumor patients, no patients had delayed surgery for any hardware loosening. There was no fractures, and 3 tumors recurrences were detected in patients, and that too in early phases of 2 mm recurrence. So this allowed the radiation oncologist to give radiation to that particular area through SBRT. Second, these hardware enhances safety efficacy, particularly in particle therapy dosimetry. That is the next generation of radiation that is called as a proton therapy. So there are encouraging results from multicentric trial from Japan as well as the US. Coming to the second center. So if you look at this gentleman, Stefano Boriani, from the Rizzoli group, who has done a lot of work on spine oncology, he also started up with his carbon fiber implant therapy from 2018. And he has come up with a large paper in 2023. So they also identified the radiolucency and reduced artifact occurrence in carbon hardwares. So if you look at this postoperative CT, postoperative MRI, if this was a titanium implant, you would have never seen this spinal cord with CSF fluid. But in this case, the carbon implants have been used, and you can see the spinal cord as well as the CSF, that in the postoperative period. It reduces almost 90% of the artifact. Second, if you look at this case series from the Rizzoli group itself, the 34 patients with 232 carbon element screws, there was only one intraoperative complication of the tulip fracture. And 6 patients, they had local recurrences, but they again were identified at the early stage. So Dr. Boriani group, they also summarized and gave encouraging results about the carbon fiber. So from the Japan we have, from the Italian group we have positive results. Coming to the other 2 major centers in the planet, that is the MSKC group, the Memorial Sloan Kettering group, and the MD Anderson. MSKC group also said it is because of the radiolucency and less scattering of the radiation. There is equivalent distribution of the radiation to the entire tumor volume, and that leads to better outcomes in the postoperative radiation. They also found better visibility around the area of construct and lack of significant artifact and dose perturbation in cases of carbon fiber implants. And this is, again, the largest series which has come from the MD Anderson group. They also have seen cases of almost 69 patients with almost around 500 pedicle screws of carbon. They found the hardware complications were only in 5 cases, which is almost similar to what we see in the general titanium implants also. And in the key cases, the disease progression, if any found, was at the very early stages, which could have been tackled with SBRT. So we have multiple centers which have come with great results in the cases of carbon pedicle screws. But that is not all about the carbon implants. There are pitfalls also. So I told these 4 centers have been doing this work. And this cannot be emulated to the developing countries by using a carbon implants, just because the cost is almost 6 times that of the conventional titanium implants. So that is a rate limiting factor we have in this present generation. Second is based on the ergonomics. The smallest screw of a carbon implant is 5 mm. So you can't use for cervical cases, lateral masses. So those areas we lack. And the largest size rod is around 160 to 170. After that, the tensile strength drops down. Second and third, we don't have a large series RCT studies based on this, so we don't know about the long-term impact of implant breakage and the screw loosening. So these are the pitfalls we have for the carbon implant. But considering very positive outcomes, I would like to give a message to all the delegates that carbon implants are biomechanically similar to titanium implants. The better radiolucent, dose perturbation and radiation scatter is less. Better target volume can be estimated by our radiation oncology colleagues, and any local recurrences could be identified early. So this, my friends, is going to be the future, and I'm sure in MISSAP 2034, that is 10 years from now, we'll definitely have a carbon fiber product launch. And I look forward to that MISSAP 2034. Thank you so much.
Wow, very good presentation.